So good morning, my name is Jenna Faircloth. I'm a clinical pharmacy specialist at Texas Children's Hospital, and I'm the cystic fibrosis pharmacist for the Baylor College of Medicine Pediatric Cystic Fibrosis Center. I'm joined by my wonderful co-chair, Kathleen Odell, who is a pharmacy technician at the St. Luke's Cystic Fibrosis Center of Ohio. Idaho. Sorry. Thank you. I apologize. That was a slip. So thank you all so much for joining us bright and early this morning. We have 4 absolutely outstanding presentations this morning reviewing challenging pharmacotherapy-related cases, and we're going to be presented by the experts who manage these cases. To begin, Kathleen and I myself have nothing to disclose related to this presentation. The objectives of this session are listed here for your review, and they're also available for review in the app. But for time's sake, we're going to move on. And before we begin, I do just want to mention that we're going to do questions immediately following the presentation. So please ask those throughout the presentation in the app. Y'all may be familiar at this point where to go locate that, but you'll locate our session DG20, and then you'll find the Q&A section in the navigator at the bottom, and then there will be a questions tab in the middle. I think it defaults to the discussion section, but we want to make sure we select the questions section so we're able to see those. You can vote on those to prioritize questions if somebody asks a question that you're very interested in, to ensure that gets asked first, but we are going to go ahead and begin with our first presentation. So our first presentation, we have Dr. Joshua Fleming joining us. Dr. Fleming is a clinical associate professor with the University of Mississippi School of Pharmacy. As part of his role with the School of Pharmacy, Dr. Fleming serves as a clinical pharmacist for the University of Mississippi Medical Center Adult and Pediatric Cystic Fibrosis Clinics. Dr. Fleming completed his doctorate at the University of Tennessee Health Science Center, PGY1 pharmacy practice residency at Campbell University, PGY2 residency in ambulatory care at the Johns Hopkins Hospital. Dr. Fleming will be presenting on experience in elexacaftor, tezacaftor, ivacaftor pre and post liver transplant.
Good morning. I'm not used to standing behind these things. I'm usually like a Baptist preacher and walk around, so I'm going to try really hard to stand behind the podium. Thank you for the warm welcome. Jenna and I go way back, so Jenna graduated a year behind me in pharmacy school, so it's good to see Jenna again after a little bit of time. Feels like it was only yesterday. We're going to say it was only yesterday.
Yes.
But delighted to be here this morning with you guys very early on a Saturday morning to talk about this interesting patient case. And I have messed us up already. Uh-oh. Oh no. What'd I do? Hit a button. While we're fixing my slides, there it is. All right. I did want to kind of bring this to you guys because as pharmacists, we like having answers. We're type A people. We like having data. We like having evidence. We like having trial data. But as we all know who practice in this particular area, we don't always have that in this particular space. And for the purpose of this presentation, I will be using ETI instead of saying elexacaftor, tezacaftor, ivacaftor several times over the next few minutes. But for me, as Jenna has said, I'm Joshua Fleming, Clinical Associate Professor with the University of Mississippi School of Pharmacy, and work with that fine team of individuals at the back table there at the University of Mississippi Medical Center Adult and Pediatric Cystic Fibrosis Clinics. No relevant financial disclosures, but if you have any financial disclosures you want to throw my way, I'll be glad to take those. I did want to bring this guy to you guys this morning. So this was one of those Houston, we have a problem kind of cases. So I'm going to introduce TD, a 22-year-old Hispanic male with a past medical history of cystic fibrosis with pancreatic insufficiency. He was diagnosed at 14 and had a pancreatic stent placed at around 11 years of age and also had a history of GERD. Up until this recent event, he had been doing very well, very adherent to therapy, one of our favorite patients to see in clinic, one that we really spent more time visiting than really dealing with therapeutic issues or anything of that nature when he came into clinic. Up in November of 2020, this was his med list, pretty typical for a CF patient in our center. He started ETI in April of 2020. He was not tolerant to hypertonic saline, pretty typical for a lot of our patients. His previous CFTR experience was on Tezaiba and was on that from 12 of 2018 to April of 2020 with no real significant issues tolerating that therapy or any other lab abnormalities with that therapy. As I stated, adherence for this guy was very, very good throughout his history. In November, his FEV1 was 77% with a personal best of 81%. His weight was great, BMI was great, and then this is his history of LFTs going back to 2016. You see the one little bump there. I can't really exactly remember what that bump came from, but outside of that one bump, we really haven't seen any unusual LFT elevations in this particular patient. In January of 2021, I got a call from our transplant team at UMMC about TD and was wanting to know how adherent he was to therapy. And I was like, why are you calling me? Because this is not what I would expect for this guy. So he was admitted to an outside hospital with severe abdominal pain, nausea, vomiting, diarrhea, severely elevated LFTs, prolonged INR, and an acute renal failure. He was transferred to UMMC for emergent liver transplant. And he did what normal 22-year-old young men do when they finish college. He went out to celebrate with friends, had a little bit of drink, didn't really eat a whole lot, and in order to treat his hangover symptoms, took a pain reliever that he had thought was ibuprofen that was given to him by a friend, but turned out to be acetaminophen. And we estimate that he took about 3,000 to 4,000 milligrams of acetaminophen over about a 24-hour period. His initial acetaminophen level upon arrival was 9.1. And, in typical 22-year-old male who goes out and drinks and takes Tylenol for a hangover, about this amount probably wouldn't have ended up in acute hepatic failure. So this brought a lot of what the heck's going on here? Questions with this young man. Brief admission history. I work on the outpatient side. Team up a lot with our inpatient pharmacists, but in terms of following him on the inpatient side, they take care of a lot of that. So he was transplanted on January 25th of 2021. His pathology was consistent with drug and toxin injury. His LFTs trended from greater than 7,000 on admission, and by discharge, he was at 197 and 27 AST and ALT. We did hold his ETI. Obviously, in this particular case, we've got a brand new liver that needs some time to settle in, and we've got a lot of new transplant meds that need some time to be adjusted. But we did continue his other CF therapies, and he was discharged successfully on February the 2nd of 2021. As he was discharged, that brought about a lot of the questions of what do we do? So what contributed to this guy having acute hepatic failure after this amount of alcohol ingestion and this amount of Tylenol? Is this something that we need to be aware of more in our patients with cystic fibrosis? Is it something we need to counsel more on? Did ETI play a role here? And then what do we do with his ETI? So obviously he still has CF, he still has CF lungs and all the other complications there. How do we restart it? When do we restart it? At what dose do we restart it at? And then how long do we wait before we restart it? And then once we restarted it, there's obviously drug-drug interactions with ETI and a lot of transplant medications that we use. So to dig further, we first looked at the risk of hepatotoxicity. We weren't starting ETI right away, so we wanted to kind of dig into the why question first. So in this particular population, what we've learned is that patients with cystic fibrosis have a lower, reduced glutathione stores. Glutathione is one of the major pathways of metabolizing NAPQI, which is one of the major metabolites of acetaminophen. This is the toxic metabolite of acetaminophen. And so without that glutathione, we are slower at breaking down NAPQI. You add alcohol on top of that, and that slows that even further, and then add the fact that he didn't eat anything, and we've slowed that down even more. So we've done a lot of things there that have really messed with our ability to metabolize acetaminophen in the way that a patient without cystic fibrosis would be able to metabolize acetaminophen. So it's almost a perfect storm in this particular case. At this point, we don't really think that ETI played a significant role in this particular case. His LFTs were stone cold normal heading into this acute event. So I don't feel like that was a role in this particular case. So our next big question is, how do we restart? When do we restart? So fortunately, he was transplanted at our center, so we're able to work very closely with our transplant team to come up with a plan. We did wait for all of his transplant therapies to become stable so that when we added back in Trikafta, that we would know what effect that had on his tacrolimus level, and know that that was what was causing it and not just the normal adjustments that happen early on post-liver transplant. There is meds there at discharge that he was on, and the things that we had to consider when we were looking at restarting Trikafta for this guy. Our first visit post-discharge, I apologize for the typo there, was March 21st of 21. From a CF perspective, he looked great. His FEV1 was maintaining well, weight was maintaining well, even though he's just a couple of months out from a transplant. BMI still looked great. We were still holding his ETI, and no real major changes at this visit, as they were still kind of getting his tacrolimus level adjusted. We ultimately decided to restart May 28 of 2021, and we hesitated for a bit about what dose to restart. The only other case that we had heard of regarding restarting ETI post-liver transplant was in a pediatric patient in a neighboring institution, and they were a year out from transplant, and that individual did have a rise or a bump in LFTs about 2 months after starting ETI. And so there's consideration of do we just go full dose, or do we start back at about half dose and see how he responds? We elected to go full dose. Like I said, we had a close relationship with the transplant team at UMMC, and we're able to get his LFTs and tacrolimus levels monitored weekly there for a good while, so that we could really make acute adjustments if we needed to either therapy as we were getting that restarted. LFTs. This is LFTs from May 2021 up until his most recent visit. So as you can see, nothing really jumps out at us. Our highest LFT, I think, is in the 40s since he's been transplanted. So he's done remarkably well 1 year out from restarting Trikafta post-transplant. And so this gives me a lot of hope in being able to use the therapy in these particular patients without causing too many issues with a new liver. Tacrolimus levels also trended well. You do see the one big bump there in January. This was not a true trough for his tacrolimus. He had accidentally forgotten and taken it the morning before he went to the lab. So he had a little bit of a bump there, but outside of that, his tacrolimus levels have trended well over this last year and really haven't shown just a whole lot of issues with that potential drug-drug interaction with the ETI. Our most recent follow-up was in July the 6th, so just a couple of months ago. His FEV1's back up, better than it's been since prior to transplant, 88%. Weight looks great, BMI looks great. And one of the things that I wanted to kind of bring, he did allow me to use a picture of him. When we talk about these kind of patients, and especially when I talk about these kind of patients with my students and my learners, I think they have in their head that these are very sickly looking patients and they don't have lives and they don't live and do normal things. So I like to include this photo just so that you can see that he lives a normal, happy life. I mean, he had a rough few months, but now we're back. We're running marathons. We are going to concerts. I think this one is Hippocampus Campus. I'm not young enough to know what that means. But he was very excited about it. My students were too. So, and then has a few tattoos. He's a big Harry Styles fan, so very specific Harry Styles kind of tattoos going on. And he's just living his best life. And we couldn't be more proud of him just because of all the things he's been through over this last year and continue to maintain good adherence. He is now working as a CPS person for us in the state. So somebody that we may have to use at some point in the future. But He's been a great partner for us in learning about him and being able to then teach others. So it's something that we have actually incorporated a little bit more discussion of, let's be careful with using Tylenol in our patients with cystic fibrosis, especially around alcohol ingestion and those types of things, so that we have been a little bit more cautious in using that potential over-the-counter therapy that people have so much ready access to. It's not just for headache, you've got all your sinus therapies and those types of things that also include acetaminophen in them. So we've had a lot more counseling with especially our adult patients in this particular regard, so that we can potentially avoid this potential outcome in the future. With that, I was quick. Saved you some time, Jeff. Any questions about TD?
So seeing no questions in the app so far, please feel free to submit those in the question section of the app. I'll go ahead and get us started.
Right.
So since this experience with this patient in your clinics currently, how are y'all approaching counseling with taking ETI with regards to alcohol?
It's a great question. So again, the question was related to ETI and alcohol. So obviously this was a very acute case here, and we've been very mindful of talking about acetaminophen with our patients. Alcohol is something that does come up pretty frequently, particularly in some of our adult patients, but it is something that we've had to be more mindful of in those discussions. Sometimes, it's kind of hit or miss in terms of whether or not they're going to be truthful with us about their alcohol intake, but it is something that we do want them to be aware of, especially if they choose to drink alcohol. It's not necessarily unsafe to drink alcohol in small amounts, but it's just being careful with the amounts and what you're doing if you have side effects from that alcohol ingestion and what you're doing to treat that. Very good question.
Thank you. Very relevant. Any other questions? Feel free to shout out.
Yes. It's a great question. So her question was related to getting any liver imaging or any further liver workups routinely with basically normal LFTs. To my knowledge, I don't know that we do a whole lot of advanced liver workup unless we see LFT aberrations. And at that point, we typically work with our GI folks to get a further liver workup, ultrasounds, and those types of things to really see what else may be contributing to the potential for liver disease in that particular patient. But with normal LFTs, we typically are not going and getting that particular advanced workup right now. My team may tell me differently back there.
And it looks like we have a question in the chat, and they want to know what all went into the decision to wait 3 to 4 months post-transplant to restart ETI.
Great question. So waiting 3 to 4 months for us really, again, as I talked about a little bit earlier, without a whole lot of guidance with when to restart, how to restart ETI in this particular population, in this particular scenario, we really wanted to make sure with our transplant team that they felt comfortable and wanted to make sure that all of their transplant therapies were adjusted and stable, and the liver was stable, and everything looked good as it could prior to restarting Trikafta, so that when it restarted, we would know exactly what effect that particular therapy had on transplant meds and the other therapies that he was on at that time. But by and large, it really went well for this particular patient. I can't say that it would go well for every single patient, but it did go well for this one guy. All right. Yes?
Was he ever on any antifungals preventative after transplant?
He very well might have been, but I don't remember.
We ran into a similar situation with Control, and
Adjust. Yeah. He may have been on an antifungal there for a bit post-transplant, but I can't recall off the top of my head.
We have another one in the chat, and they want to know, did you restart ETI post-transplant at full dose?
We did. We did go back full dose, 2 in the morning, 1 in the evening. He was tolerating that prior to transplant, has tolerated that well post-transplant without any changes in LFT so far.
Just a
Yes.
random question. So now with the updated GI guidelines to
Yes.
get an ultrasound every 2 years in all patients,
Yes.
with diagnosis, which I just went to another session, do you think that that could have caught something that was going on where you didn't, your hepatitis or potentially damage
No.
when you don't
Yeah.
have that LFT elevation, or do you think this was really more of an just a situation?
And this particular, I don't know if this would have caught anything particular for this particular individual, just because I feel like everything looked good for him up until this point. Now, bringing that back to our team and looking at doing these advanced imaging a little bit more frequently is probably not a bad idea for a lot of our teens and adults and others, but I feel like this was a lot more this acute event. I think it was more the perfect storm of alcohol, Tylenol, and no food over a short period of time that led to this particular event. You'll see this in non-CF patients, but it's usually a little bit more Tylenol on board or a lot more alcohol on board. This wasn't when we say alcohol ingestion, we weren't talking like a whole huge amount of alcohol. We're talking, one evening, I want to say it was more on the hard seltzer side of things, 3 to 4. So it wasn't like he went out and was drinking hard liquor all night. He had a relatively normal amount for a 22, 23-year-old celebrating after finishing a degree, and a relatively small amount of Tylenol. Yes.
So did you think about maybe getting some blood to actually look at the level? Because there's data on the pharmacodynamics. Maybe he had a very high DTI level in combination with alcohol, combination of course. I mean, if that ever happens, anybody can save some blood because that may be just someone who has a very high level at propensity to do that. I know it was a year or so ago, but
Yes.
but, those assays are available now. That might be
Okay.
understand this.
That's a great idea. So for those of you who didn't hear that, so apparently there's some assays out there now where we can test ETI levels, especially in an acute case like this, to see if that did play a role in this, if this were to happen again in the future. That's a great idea. Definitely something we can incorporate. Yes. Yes. It would help us to know more about the potential drug involvement in the future. It's a great idea. Yes.
Are you aware of any other case reports of acute Tylenol toxicity prior to ETI or without in CF?
Yes. The question was related to any other case reports for modulator therapy and potential for liver involvement and those types of things, transplant. I think.
No, the question was, have you seen other cases of acute Tylenol toxicity
Yes.
without
Okay.
ETI involved in CF?
Acute Tylenol toxicity in with CFTR modulators in CF, correct?
With modulators
With
not
mod-
on board. So just
okay.
just the
Got it.
use glutathione and cystic fibrosis.
Yes. There is a paper out there that did kind of talk about this glutathione issue, and I think it's cited in my slides that talks about the issue of decreased glutathione stores in CF. So I would imagine that there are some case reports or something out there that have contributed to that particular report that we used to kind of look at the decreased glutathione stores and potential plausible thought behind why this might have occurred outside of the modulator.
Well, thank you very much.
Thanks, guys. Have a great meeting.
Okay, thank you, Josh, for that excellent presentation. So for our second presentation, we have Dr. Carissa Cam. Dr. Cam is a pediatric pulmonary clinical pharmacist practitioner at University of North Carolina Medical Center. In Chapel Hill, North Carolina, primarily caring for pediatric CF and lung transplant patients. She received her doctorate of pharmacy degree from from UNC Eshelman School of Pharmacy and completed her PGY1 and PGY2 residency training at Texas Children's Hospital in the wonderful city of Houston, Texas. Dr. Cam will be presenting today on the tipping point, weighing the benefits of highly effective modulator therapy against weight gain.
Not as tall as Dr. Fleming. Thank you for the warm welcome, and thank you so much for the opportunity to present this case to you all. So I have no disclosures related to this presentation. And hopefully by the end of this presentation, you should be able to define body mass index goals in people with CF and summarize and compare current cystic fibrosis nutrition guidelines, describe the historical and current trends of overweight and obesity in people with CF, as well as discuss the clinical implications of overweight and obesity in people with CF, and then lastly, design a patient-centered plan to optimize the clinical benefits of highly effective modulator therapy while minimizing undesired weight gain. So let's first meet the patient. Whoops, I'm going backwards. Let's not do that. So let's first meet the patient. She is a 6-year-old female with CF. She is heterozygous for F508del. Her second mutation is a class 5 mutation of note. She is pancreatic insufficient, and as you can maybe tell by her weight, she is obese. She's actually classified as class 3 obesity. And then earlier this year, when we were meeting her, she was diagnosed with ADHD and oppositional defiance disorder. Please note, we are meeting this patient in May 2021. So elexacaftor, tezacaftor, ivacaftor, which I'll be using Alex-Teza-Iva the rest of this presentation, has not been approved yet in this patient age range just yet. However, at this visit, we do know that the approval is coming soon, so we wanted to discuss that with the family. With regards to other family histories pertinent for maternal and paternal obesity, of note, the patient's father did unexpectedly pass away in 2016, and because of that, the child also started using eating as a coping mechanism. This is her current medication list, so a fairly standard list with some airway clearance medications, PERT therapy, PPI. And as I mentioned, her second mutation was a class 5 mutation, so she did qualify for ivacaftor, a highly effective modulator. And so she actually was started on ivacaftor 75 milligrams twice a day in October of 2017, but about a year later, we had to stop it due to excessive weight gain. And I'll show you her growth charts in a minute. And then from a lung function perspective, as you can see in reverse chronological order, her FEV1 is actually, she's fairly healthy. Her most recent in February was 101, mostly grows oral flora, some MRSA. Her last oral antibiotics was in January of 2020, and then last course of IV antibiotics was in January of 2018. So this is her weight growth curve. So here is where we started ivacaftor, and this is where we stopped. As you can see, her weight took off. We stopped the ivacaftor with hopes of slowing that trajectory. Obviously, we failed. And here is where we are meeting the patient in May of 2021. So she's at the 99th percentile for weight. And then looking at her BMI, similar time points, and her BMI here is the 99.8 percentile. And for pediatric patients who are obese, there's also the extended CDC BMI growth chart, which also lists out what percentile of the 95th percentile these children are, which will play into classification, which we'll talk about momentarily. But you can see even in September of 2018, when we stopped ivacaftor, she was at 140% of the 95th percentile, which would classify as class 3 obesity. And this is where we are meeting her in May at 163% of the 95th percentile. So at this visit, we are posing the question, would you start Alex-Teza-Iva in this patient? So at this visit, given the patient's clinical stability and concerns for continued weight gain, we decided to hold off on Alex-Teza-Iva for this patient when it would be approved for her, at least until the patient's weight trajectory at least stabilized and didn't continue to increase, or if she started having clinical symptoms and worsening of her pulmonary disease. The mother also was very concerned about excessive weight gain if we were to start. However, we did want to make sure we had a comprehensive plan in place for this patient to make sure that we were addressing all facets of her care. So continuing her current airway clearance therapy regimen with close monitoring of her pulmonary symptoms, encouraging the child and the mother to increase physical activity. Our wonderful nutritionist spent a lot of time with nutrition counseling as well as making recommendations for healthy food choices, and then also addressing the mental health and psychiatric aspects. So she was referred to psychiatry for further management of her ADHD, as well as referred to a behavioral therapist. So let's pause here on our patient case and let's take a look at current guidelines and nutrition recommendations for people with CF. Just a quick note, you'll see BMI and BMI percentiles used a lot. However, fat-free mass is actually your best marker for nutritional status in people with CF. However, BMI and BMI percentiles are most commonly used just because of ease of use. So this table summarizes the recommendations from the US, Europe, and Australia and New Zealand. And as you can see, the recommendations are fairly aligned. So for pediatric patients, a BMI percentile of greater than 50, and then for your adults with CF, a BMI of greater than 22 if you're female, and greater than 23 if you're male. However, in 2020, when the Australian and New Zealand guidelines were released, they actually snuck in something new. They actually recommended a cap for our goal nutrition because of this increased weight gain that we have been seeing. So for pediatric patients, less than the 85th percentile, and for adults, less than 27, BMI of less than 27. So historically, the recommended energy intake for people with CF was 110 to 200% of the energy requirements for the healthy population. So where did this recommendation originally come from? So the seminal study that resulted in the widespread use of what is now known as the legacy CF diet, the high-fat, high-calorie diet, came from this paper by Corey and colleagues in 1988. And in this study, what they did was compared two different pediatric centers, one in Toronto and one in Boston. And the children in Toronto were prescribed a high-fat, high-calorie diet, whereas the children in Boston were receiving standard of care. And what they found was that the children in Toronto who were prescribed the high-fat and high-calorie diet had a 9-year survival advantage. And again, this is what led to the widespread use of our legacy CF diet. So over the years, it's been confirmed that nutritional status is directly correlated with outcomes, specifically lung function and mortality. We know that with lower BMI and malnutrition, we tend to have lower lung function, especially if your BMI is less than the 15th percentile, you have higher rates of mortality. So in these figures from the CF Foundation Patient Data Registry, on the upper left, you have pediatric patients. On the lower right, you have your adult patients. On your y-axis is your percent predicted FEV1, and across your x is your BMI percentile or BMI. And the vertical lines are our current nutritional goals. And you can see that as BMI increases, your lung function does increase, and you see that positive slope of the line. However, once you start getting towards our nutritional goals, you start seeing a plateauing type effect of that slope of the line, indicating that potentially as you continue to gain in BMI, you might not see a similar increase in lung function. So what have the trends in median BMI values looked like over time in people with CF? So this is data from the last 2 decades. On the left, again, your pediatric patients, and on your right, your adult patients. And as you can see in both patient groups, nutrition goals, so BMI, in the pediatric patients, some of their other anthropometric parameters are all steadily increasing. And then if you look at the graphic on the right, especially in the last 5 years or so, you can see a even more dramatic increase in BMI for adult people with CF. Now, before we go any further, let's first define our weight categories. So the CDC and the WHO also have recommendations for what is considered a healthy weight. So for pediatric patients, that's between the 5th and less than 85th percentile. And for BMI for adults, 18.5 to less than 25. And then they have categories for being underweight, overweight, and then obese. And then as you can see, there are 3 classifications for obesity. For the purposes later on of our case, I'll just point out for class 1 obesity for pediatric patients, that's less than the 120% of the 95th percentile. For class 2, that's between 120 to 140% of your 95th percentile. And then for class 3, that's greater than or equal to your 140% of the 91st percentile. So we know that in the non-CF patient population, we've had an epidemic of obesity and overweight, but has there been a similar trend in people with CF? So since the advent of Alex-Tazaiva, I know for me and our team, this excessive weight gain has been at the forefront of our minds. However, as I was preparing for this talk, I was surprised to find that this trend actually has started since the early 2000s. Maybe I'm behind the times, but I did find that quite surprising, because that would mean that this trend of overweight and obesity predates the widespread use of highly effective modulator therapy. Some hypotheses are potentially the widespread use of the legacy CF diet, optimization of PERT therapy, or earlier diagnosis and better treatments. But this table is a selection of studies looking at a variety of CF centers and their reported rates of obesity and overweight in their respective centers. And as you can see, it spans a wide geographic region, so from the US to Canada and Europe. And as you can see, the rates of overweight range anywhere between 6 to 25%, and rates of obesity range between 1 to 8%. There's two other things I'd like to point out. For example, the Kastner and Cole study, that second one, they only included their homozygous F508del patients, and they still saw rates of about 10% of overweight and 1% of obesity. And then also, if you look at the study timeframes for all of these studies, it actually did not include widespread use of Alex-Tazaiva. I heard in a recent session during NACFC that there's been a 40% increase of patients who are overweight, and 49% increase from the most recent CF data registry of people who are actually obese. So these are some astounding numbers. So certainly impacting our patient population. So what leads to weight gain? It's all about balance. So if you have a positive energy balance, this is what results in weight gain. So some factors include overnutrition. CFTR modulators have revolutionized CF treatment, so decreasing exacerbations as well as making wonderful improvements on the GI tract and digestion, so our patients are absorbing more of the nutrition that they've been taking in. Additionally, for anybody, if we live a more sedentary lifestyle, you're going to probably gain more weight. And then other risk factors that have been identified with overweight and obesity in people with CF include pancreatic sufficiency as well as milder genotypes. Then on the flip side, you have net negative energy balance, which would result in weight loss. So if you're putting in less calories, you have a higher likelihood of having net negative energy. People with CF also tend to have a higher resting energy expenditure, especially if they're having frequent exacerbations, have more severe lung disease, and then people who are chronically colonized with Pseudomonas also have higher resting energy expenditure. If you're more physically active, you're burning more calories. And then other risk factors associated with malnutrition include pancreatic insufficiency as well as some of your more severe genotypes. So what are the implications of overweight and obesity in people with CF? The long-term outcomes have not been described in this patient population. A lot of this is due to historically people with CF have had shorter life expectancies, and now that has changed, so we just don't have a lot of information about this. There are some potential benefits. As previously mentioned, the higher BMI has been associated with higher lung function, although there are some studies that note that there's no additional lung function benefit beyond a BMI threshold of between 23 to 25. Interestingly, there was a 2020 meta-analysis conducted by Nagy and colleagues that included a lot of the papers that I summarized on the last table, as well as a couple others. And interestingly, though, they found that people with CF who were overweight or obese still had higher ppFEV1 than people with CF who had a normal body weight. So people who were overweight had a ppFEV1 of about 83 versus 75, and those who were obese about 85 versus 73. However, they do note that there was a lot of heterogeneity between all of these studies. So definitely a lot more to find out about this. Now, certainly there's definitely potential risks. A lot of this we extrapolate from our non-CF patient population, but there's concerns for metabolic disease as well as potential insulin resistance. The meta-analysis that I mentioned earlier did not find that people who were overweight or obese necessarily had a higher rate of CFRD or insulin resistance. We certainly are concerned about cardiovascular disease, which previously had not been described well in this patient population. But there are case reports of hypertension, hyperlipidemia. I believe recently there was a case series published of 2 adult patients who experienced a STEMI. But interestingly, that 2022 meta-analysis found that people with CF who are overweight or obese, they did have statistically significantly higher levels of total cholesterol and triglycerides, but it should be compared to normal weight people with CF. But it should be noted that although it was statistically significantly higher, their triglyceride levels still were within your normal limits. We also worry about macro and microvascular disease, especially if patients have concomitant CFRD. And then for anybody, if you're obese or overweight, you do run the risk of obstructive sleep apnea. Excuse me. So now let's go back to our case. So now we're picking up in February of 2022. The patient is now 7 years old. In the interim, she had been referred to endocrinology as well as genetics just to make sure that we weren't missing any other genetic causes, but those were all ruled out. You can see that her weight is 38.9. You'll see on the growth chart she is now class 2 obesity. And then medication-wise, she was started on 2 ADHD medications in September of 2021. However, when we look at her lung function trend from where we picked up in where we last saw her in May, you can see she's had a steady decline in her lung function as well as multiple courses of oral antibiotics. She also recultured Pseudomonas actually at that May 2021 visit. And the mother also notes the patient being more symptomatic, having increased cough and decreased energy. So the additional interventions, as we mentioned, she had multiple courses of antibiotics. The mother did a great job trying to enforce increased physical activity, but this was difficult due to her pulmonary symptoms with her clinical decline, if you will. The mother did an excellent job implementing the advice of our nutritionist, so using portion control, set meal times. She set a no snacking after 6 p.m. rule, and they were starting to use healthier food choices, such as more fruits and vegetables and switching from whole milk to skim milk. And then from the mental health perspective, she was started on ADHD medications, like I mentioned, and the behavioral therapist provided multiple strategies for impulse control, especially surrounding food. So given the patient's increased number of exacerbations, as well as her excellent progress with weight loss, through shared decision-making with the mother, it was decided to start Alextase-IVA. However, the question becomes, how would you dose this in this child? So if you look at the package insert for Alextase-IVA in children between 6 to less than 12 years of age, your kind of weight cutoff is at 30 kilograms. So if you're above 30 kilograms, you would receive basically the adult dosing, which that would be what our patient technically would fall under. However, knowing that this patient previously on ivacaftor had a really excessive weight gain, our team began discussing, could we use a modified dose to optimize pulmonary benefits but try and minimize some of that weight gain. And so as we were discussing this, it also brought up the question, so what would this child's ideal body weight be? So how do you dose, or how do you figure out ideal body weight? There's actually multiple ways. There's at least 5. We ended up doing a hybrid between the McLaren and Moore methods. But basically, we took her current BMI and height from that day, and we looked at if you were to calculate or figure out what her 50th percentile BMI should be, then what would that weight be? And then we decided to also look at the 85th percentile, since that's right at that threshold between a healthy weight and being overweight. So if you drop a vertical line and where it intersects with your 85th and 50th percentile, then you can back calculate. So for her 50th percentile weight would be 25 kilograms, her 85th percentile would be 27 kilograms. So because of this, we ended up deciding to go with the lower dose, which is basically half of the adult dose for the less than 30 kilograms. So we'll follow up at her second follow-up visit in August of 2022. So the mother reports that she has markedly decreased cough, and that, quote, she was so excited to be able to play tag with her friends. So there's her new medications. And as you can see, her lung function had a significant bump up. We did treat her with a course of Bactrim right before starting Alextase-IVA in March. And then the mother continued to implement all the prior interventions that we had mentioned, but I do want to point out that it was much easier for the child to implement increased physical activity now that she was feeling much better while being on Alextase-IVA. Now, the million-dollar question is what happened with her weight and her BMI. So this is her growth chart, and so this is where we started ADHD medications, and they started implementing all those other interventions, and you can see that she's having a decrease in her weight, and these are her weights from the last 2 visits. But even more remarkably, on your extended BMI chart, again, where we started ADHD medications, she was still at class 3 obesity. When we started Alextasiva, she had already made progress and moved down to class 2 obesity. And then here, she's now at class 1 obesity. So in conclusion, the prevalence of overweight and obesity is rising among people with CF. However, we don't really fully understand the long-term outcomes and the potential metabolic and cardiovascular complications in this patient population. And especially in patients where it's maybe not as clear-cut whether or not to start highly effective modulator therapy, potentially due to adverse effects like weight gain. It's critically important to tailor pharmacotherapy and nutritional goals to the individual patient. So thus, the role of the multidisciplinary team really cannot be overstated in addressing all facets of patient care. And then lastly, careful initiation of Alextasiva, even at modified dosing in overweight and obese people with CF, potentially can maximize pulmonary benefit while also minimizing weight gain. So with that, I'll be happy to entertain any questions or comments.
There's some questions in the chat. So the first one is, what do you see for future use in monitoring of ETI with statins?
With statins, is that the question? Okay.
Yes.
Since I work in the pediatric world, I might not be the best source of information on that. But I think a lot of it also will depend on which statins we are using because of potential drug-drug interactions. As far as I'm aware, again, it's not my area of expertise, but there really is not a lot of information about hypercholesterolemia and things like that. Some of the case reports that I had mentioned of the rates of obesity and overweight, those centers did report out, cholesterol levels and all of that, but I'm not aware of that. But I would presume eventually, as we start learning more, maybe potentially some of your ASCVD risks for the non-CF population might apply to our adult people with CF.
Perfect. And then was she pancreatic insufficient prior to ivacaftor use? And if so, was there any testing to see if she had return of pancreatic function while on ivacaftor?
Yeah, that's a great question. So she was pancreatic insufficient. We did not at that time when she was on ivacaftor retest, but based on symptoms, mother had reported other symptoms of malabsorption and steatorrhea if she had missed. So just from a symptomatic perspective. We have considered rechecking her fecal elastase more recently since she's started Alextasiva, but that has not been done yet.
Perfect. And then did you run into any insurance approval issues using the lower dose?
We did not have any issues. We did have a question from the pharmacy, so that actually was a good catch on the pharmacy side, but we explained why, but we did not have any issues with insurance approval.
Perfect. And then last one in the chat was, what do you recommend for high-fat foods to take with ETI in obese patients?
That's a great question. That's also where we tie in our nutritionists as well for healthy fat choices as well. So with her, I think we negotiated, potentially with when she was taking her Alexacaftor, Tasacaftor, ivacaftor, then we could do some whole milk or other healthier fats. Also taking into consideration the patient's socioeconomic status and what they are or are not able to get. But I think if we're able to get some more of the healthier fats in as opposed to more of your saturated fats, that might be ideal. And talk to your dietitian.
Sorry, and then there's another one. In monitoring efficiency given modified dose, did you repeat sweat chloride in addition to symptoms and lung function?
That's a great question. We have not tested sweat chloride yet for her. That was something we have been discussing, but I think just based off of her symptoms and also her lung function, we feel fairly confident that she is doing well, but potentially that will be something we look into.
Any other questions from the crowd? Feel free to shout out.
Yes, question in the back. Absolutely. I think a lot of that is credit to obviously the multidisciplinary team and then also the mother implementing a lot of these strategies, more so than even being on Alextazide. If anything, she had that working against her. So I think definitely starting the ADHD medications we know can decrease appetite, suppress appetite, but like I mentioned, also her being able to participate more actively because she was feeling better, that also is kind of weighing on the other side. But those are definitely probably the bigger factors that helped with her weight loss.
And another one in the chat. In pediatric patients who are over the threshold for adult dosing but are obese or overweight, would your recommendation going forward to dose based on ideal goal weight? Are there any instances where you would go with adult dosing, and if patients fall below 30 kilograms, would you dose adjust to lower peds dosing?
So if I understand the question correctly, for all obese or overweight patients, would you always dose on ideal body weight? I think that might be a good place to start just to compare, and potentially you can start there and see what happens with their weight. But if their pulmonary function, for example, or their symptoms aren't resolving, you potentially could bump up higher or utilize something like sweat chloride testing. And then what was the second part of the question? I'm sorry.
Oh, that's okay. Are there any instances where you would go with adult dosing, and if patients fall below 30 kilograms, would you dose adjust to the lower peds dosing?
I think that also is a possibility as well. Again, if you are experiencing additional adverse effects, whether that's weight gain, I know our center has seen a lot of mental health and behavioral changes, and so we have adjusted dosing as well just to see if we can still maintain clinical benefit while minimizing some of those adverse reactions.
All right.
Thank you.
Okay, thank you, Dr. Cam. That was an outstanding presentation. For our third presentation, we have Dr. Joseph Rosano. He's a senior clinical pharmacy specialist at Yale New Haven Health System in New Haven, Connecticut. He practices within the Children's and Women's Pharmacy as a clinical pharmacist serving the cystic fibrosis and has been serving cystic fibrosis care since 2019. Prior to his time at Yale New Haven Health, Joseph received his doctorate of pharmacy from the University of Connecticut School of Pharmacy and completed his first and second year pharmacy practice residencies at the Children's Hospital, Philadelphia. Dr. Rosano will be presenting today on the treatment of multi-drug resistant Burkholderia gladioli in the setting of ECMO.
Alrighty. Thank you, everybody, for having me. It's been great to see you all in person. I am a COVID baby when it comes to the world of CF pharmacy, so I've been virtual for the past 2 years for NACFC, so it's great to see you all in person this year. And I'm going to talk to you today about the treatment of MDR B gladioli in the setting of ECMO. I want to give credit, this was a multidisciplinary team approach when it came to making the presentation. Not only myself, but Shelby Blaylock, our pediatric intensive care unit pharmacist, and Michelle Reichowski, our pediatric infectious diseases pharmacist. We have no relationships to disclose, but we do discuss the use of off-label medications and uses throughout the presentation. So our objectives today, we're going to introduce patient CF and describe their hospital course, review the pharmacodynamic and pharmacokinetic implications of ECMO on dosing antimicrobials and CFTR modulators. We're going to then discuss the utility of getting serum meropenem levels and their overall impact on dosing strategies. And then lastly, summarize key findings and outcomes of our case. Briefly, just to discuss my presentation format, so it's a timeline-based case presentation, so you're going to see slides that are indicated by day X as we go throughout the hospital stay, and then I'm going to have some call-out breakout slides which we're going to go into the content and data and literature that supported the decision-making at that time in the case. And as I'm talking, just to keep things high level and moving along, as the case was a 138-day hospital stay to fit into 20 minutes, I'll use things like transitions of care, escalation, change in clinical status as the reason why we adjusted therapies. So let's meet patient CF. They're an 11-year-old male with cystic fibrosis who's homozygous for F508 deletion. And as we know, F508 deletion is the most common mutation with a deletion in 3 base pairs, and you have a loss of phenylalanine at position 508, which results in the mutation. And we have CFTR responsive therapies at our disposal, and our patient was on tezacaftor, ivacaftor, tez-iva at their time of presentation. Their microbiology history was significant for Staph aureus and Burkholderia gladioli in cultures passed on both throat and sputum, and uneradicated at that time of admission. So on presentation, they presented to our ED in septic shock in the setting of what was proposed to be a multifocal pneumonia. In their initial ED course, they did receive piperacillin tazobactam, which on admission to the inpatient unit was transitioned to ceftazidime IV and Bactrim IV, while we were awaiting additional culture results and susceptibilities. And their lab values, just of note, as we're going to be talking about antimicrobial therapies and CFTR modulator therapy, highlighting their LFTs in particular, their baseline labs were normal when it came to liver function on admission. So on day 1 of admission, we did receive those first culture results from bronch, and it did show continued growth of Burkholderia and the MSSA, which was pan-susceptible. Of note, the Burkholderia was resistant to ceftazidime and intermediate to levofloxacin. And thus, based on those culture results, we decided to do the following. We discontinued ceftazidime, continued on Bactrim at a dose of 20 mg per kilo IV Q12, and initiated meropenem at a dose of 40 milligram per kilo IV Q8 infused over 15 minutes. And I want to begin my first call out slides by talking a bit about the meropenem dosing strategies that we used. So when we think about meropenem pharmacokinetics, it is a hydrophilic medication in which the volume of distribution decreases with the patient's increasing age, and it has a low to moderate degree of protein binding. The bactericidal activity of meropenem, being a concentration-dependent drug, depends on the amount of time that we're able to keep those concentrations above the MIC for our patient. And in the literature, it's cited that if we're able to keep time above MIC for at least 40% of the dosing interval for carbapenems, that's of benefit, and even more so in critically ill patients, a goal of 80 to 100% time above MIC. And we know that can be achieved by using extended or prolonged infusions and dosing strategies. And there is even some literature to suggest that plasma concentrations as great as 5 times the MIC may be required for maximal killing. And we know that achieving that goal plasma concentration when we're thinking about our time above MIC, we can't only think of it in the context of what's in the serum, but we have to think about where is our infection and treating at the site of infection. It's been cited that for pulmonary infections, the epithelial lining fluid, or ELF, is our most accurate representation of drug concentration and the estimate of activity at the site of infection. And there have been Monte Carlo studies that were done using BAL cultures that showed that the estimated concentration or penetration ratio of meropenem in the lung is about 25% of your total serum level. And that concentration at that lung site should be at least 4 to 6 times the MIC to achieve that 40 to 100% time above a concentration of the MIC for the dosing interval. So based on this information, in collaboration with the inpatient pharmacist, I worked with them to tweak the dosing interval of our Bactrim to Q6, continued our meropenem at 40 milligram per kilo Q8, but then changed the infusion time to over 3 hours. And we did decide at that time as well on day 6 to reinitiate the patient's home tez-iva, which was crushed via G-tube and administered with MCT oil for absorption. And this is just my disclaimer that at that time, we know that we're instructed to administer the modulator as a full dosing strategy, swallowed whole, but there are some non-clinical stability studies to suggest immediately crushing, mixing with water, and administering, which we were utilizing that strategy for this patient as they were intubated at this time and were receiving G-tube feeds. On day 8, we received repeat cultures from an ET2 aspirate, which continue to show Burkholderia growth and changes in the susceptibility pattern. So we saw increased resistance to ceftazidime, and that MIC jumped from 32 to 256, and our levofloxacin susceptibilities improved slightly. But based on this information, we did not make any dosing recommendation changes at this time. This slide, days 12 through 18, the background here is that our patient's clinical status was worsening over this time, so we did work with our ID group to think about other changes in the antibiotic regimen that might become of some benefit or provide additional support. So over the course of these 6 days, we did the following. we initiated minocycline and adjusted our meropenem dosing from a Q8 dosing interval to a Q6 and extended our infusions further from Q3 to Q4 hours. On day 16, we initiated levofloxacin and discontinued the minocycline, and then ultimately on day 18, we initiated cefiderocol and discontinued the meropenem in hopes of improving the patient's clinical status. Unfortunately, though, by day 20, the patient did require cannulation onto ECMO, and at that point in time, for your reference, the antibiotic regimen was cefiderocol, levofloxacin, and Bactrim, and their modulator therapy was Tez-Iva. To highlight ECMO circuit characteristics and just to review what we want to consider as part of our ECMO pharmacodynamic and pharmacokinetic implications, the first is going to be blood flow. So we know that on ECMO, a patient's blood flow is going to be exceeding their normal cardiac output during the time that they're on ECMO. Heat exchange is another factor, and we know that the temperature changes in the circuit as they fluctuate, that can result in drug degradation as they pass through the circuit. And then lastly, it's important to consider the priming solution that you're using. So whether that's albumin, blood, sodium bicarbonate, as those are being administered, you are going to get fluctuations in your pH. And as you're receiving fluctuations in pH, that can affect protein-bound medications and their binding and available concentrations at the site of infection. Lastly, circuit saturation is a big one. And we know that when you initially cannulate onto ECMO or rotate any of your circuit, if you change out the circuit, you're going to have an initial decrease in that drug concentration until you reach a new saturation and a steady state. And then you're also going to have, on the contrary, drug release once the circuit is saturated at the end of the infusion. Lastly, concentration-dependent and time-dependent antimicrobials are going to be affected by these changes. So they're both equally implicated. Shifting over to drug characteristics, I want to highlight three in particular that we have to consider when dosing on ECMO, and that's going to be lipophilicity, protein binding, and the site of administration of the medication. In discussing lipophilicity, we know that the more lipophilic a medication is, the more it's going to bind to the ECMO circuit, and that is defined as a log P coefficient, and the higher the log P, the more lipophilic the medication is. For meropenem, the log P is actually negative 0.6, further reinforcing my point earlier that is a hydrophilic medication. When discussing the degree of protein binding, we know that there's going to be greater loss of more highly protein-bound drugs as they adhere to the circuit in ECMO, and that critically ill patients may actually have lower albumin levels due to being in a more of a metabolic acidotic state, and therefore you can have higher concentrations of unbound or free drug in the patient. These processes are saturable and dynamic, so require very close monitoring of the patient's overall status. And we know, again, that only unbound drug is going to be active at the site of infection. And then lastly, to consider the site of drug administration, depending on where you're infusing to the patient versus to the circuit. And this also comes into play, although not up here, is where you're drawing your levels from. So if you're doing any therapeutic drug monitoring, thinking of where you're drawing the level from in relation to the patient and the ECMO circuit, which I'll get into a little later. Lastly, I want to talk about volume and distribution and how that is implicated. So you will have increased volume and distribution due to blood priming and transfusion requirements. The higher total blood volume is going to increase the requirements of your hydrophilic medications when thinking about your dosing strategies. And then the sequestration of drugs by the circuit are going to increase your dosing requirements for any lipophilic medications. And then for overall clearance of drugs, that's going to be decreased ultimately, and it can increase your risk for medication toxicity. To dive into antibiotic PK on ECMO, most of the data is historically derived from our neonatal and infant population utilizing older generation ECMO circuits, and that data and dosing recommendations may be less relevant nowadays as we're using different ECMO circuit strategies and we have older patients on newer antibiotics, as most of the data is utilizing vancomycin and gentamicin, and those studies were performed in around the late 1980s with that boom in literature, and there's less data on, again, those newer antimicrobials. And there's no guidelines currently that exist to recommend any antibiotic dosing strategies really for these newer agents as any consensus statements. So as I mentioned, VD and clearance are going to be affected, but they can also be affected not only by the circuit, but the patient's clinical status. So our patient was in septic shock, and we did have hyperperfusion of the kidneys and liver to consider, fluid shifts, resuscitation, and any vasopressor administration. and also to consider that 30% of patients on ECMO will go on to develop renal insufficiency, and 40 to 50% will require renal replacement therapy over time. The other medication I want to call out are CFTR modulators and their use on ECMO, and the literature is limited, if non-existent. And thinking about what we had to consider when dosing these medications with our patient on ECMO. So the modulators are 99% protein bound, and we think about what is going to go into that dosing strategy on ECMO. So there is the potential then for those medications to be sequestered by the circuit, being that they're highly protein bound, but at the same time, we have to consider those pH changes and fluctuations that are going to displace the modulator from the protein and make them more readily available. So I had two conflicting hypotheses going on in thinking about dosing the medication. Ultimately, we did proceed and we're using full dosing for the Tez-IVA during the ECMO, the time on ECMO. I want to bring you to day 21 when we had our next significant culture from a BAL, which showed pan-resistance across all of our antibiotics that we were able to test against. Of note, at this time, we did test against meropenem vaborbactam, which had an MIC of 6. And the MIC breakpoint, although not defined, we did go ahead and utilize that as an opportunity to trial the patient on meropenem vaborbactam at this time. So on day 23, once that culture finalized, we took our existing regimen and we discontinued levofloxacin and Bactrim. We added minocycline back on, and we added the meropenem vaborbactam at a dose of 120 milligrams per kilo per day of meropenem, IV Q8, infused over 3 hours. And I want to dive in into a little more detail about meropenem vaborbactam. So this is a carbapenem beta-lactamase inhibitor combination, and the addition of vaborbactam to the meropenem. The benefit there is that you're going to see inhibition of various carbapenemases, hopefully. And for the treatment of Burkholderia gladioli, the activity of the meropenem and vaborbactam are going to be similar, but you will see in the literature that the MIC breakpoints of the meropenem vaborbactam are usually lower than that of the meropenem for your patient. And the dosing, again, as I mentioned, is based on the meropenem component. And for our pediatric patients in the literature, there are case reports to cite that the recommended dosing strategy used was 40 milligrams of meropenem per kilogram per dose, Q6, and that was a phase 1 dose determination study that is currently ongoing, and each dose was administered over 3 hours as an extended infusion. There was a study published by Novelli and colleagues that looked at the penetration ratios, so that ELF I mentioned earlier, in comparison to plasma of meropenem vaborbactam following administration of doses that were administered over a 3-hour infusion interval. Their study showed that after 3 hours at the end of the infusion, the penetration ratios were around 59 and 51% respectively for each portion of the drug. And after 8 hours at the end of the total dosing interval, they saw a marked increase in the penetration ratios of 185 and 95%, indicating that there's likely accumulation of meropenem and vaborbactam in the lungs over time. There's another case report by Henretti and colleagues that looked at therapeutic drug monitoring in a pediatric patient being treated for Klebsiella pneumonia who had a meropenem concentration greater than 32, MIC greater than 32, which was resistant, but the meropenem vaborbactam, as mentioned earlier, the MIC was much lower at a MIC of 0.09. So for their patient, they used 40 milligrams per kilo Q6 infused over 3 hours. And what they found is when they obtained levels on day 5 of therapy at 1 hour following the infusion, their level was 13.6. However, at the end of the 3-hour infusion, it was 51.3. And they felt that at that point in time, based on the math and the kinetics, that they were achieving greater than 40% of time above MIC for that dosing interval and that strategy. When we consider meropenem and ECMO, there is a case report of an infant on ECMO with Pseudomonas who had an MIC of 0.5, and they utilized a dosing strategy of a loading dose of meropenem at 40 milligrams per kilogram, followed by a continuous infusion dosed at 200 milligrams per kilo per day. Their serum concentrations are listed as such, but they all fell around 40 to 46 at different time points throughout the study, and they estimated that their meropenem concentration in their lung fluid was 9, and that children may require more frequent dosing strategies, even as frequent as every 4 to 6 hours, and higher dosing on a mg per kilo basis, and that degradation can occur due to the elevated temperature settings on the ECMO circuit. So they anticipated there was going to be loss through the circuit because of those temperature fluctuations, even though it was a more hydrophilic medication, as I mentioned earlier. There is limited data on meropenem vaborbactam in ECMO, but there was this case report put out by Cystic and colleagues. They performed an ex vivo study that measured the losses secondary to the ECMO circuit following administration of a single dose. And what they did was they measured pre and post oxygenator levels, and what was interesting was they found that on an adult closed loop ECMO circuit with an in-series oxygenator, they anticipated about 70% of drug loss of the meropenem after 24 hours compared to a circuit without an oxygenator where they only were seeing about 30 to 38% loss after 24 hours. So they hypothesized that the in-series oxygenator was also causing loss, not just the temperature changes in the circuit. So bringing it back to our patient CF, we had the MIC of 6 for our meropenem vaborbactam. And remember that ELF penetration ratio we anticipate is going to be around 25% of our total concentrations. So if the recommended drug concentration for us was 4 to 6 times the MIC, doing some quick theoretical math, we anticipated that our meropenem levels theoretically would need to be around 96 to 144 to achieve that concentration 4 to 6 times the MIC, which are very, very high levels for meropenem. So on day 25, we did the following with our regimen. We continued and we changed the dosing of we continued the medications as such, infused over 3 hours. We added on aztreonam inhaled. This was just of note, this was a recommendation from ID, again, due to the patient's worsening status. But on day 26, they did develop renal insufficiency, so they were placed on CRRT, and at that point, we had to increase the dosing to 200 milligrams per kilo per day of meropenem, divided every 6 hours and infused over 6 hours. So essentially, we followed the continuous infusion strategy for this patient, and we continued all of our other regimen at that time. On day 27, another ID recommendation came across our desk, which is they felt that we wanted to initiate fluconazole therapy for suspected treatment of a fungal infection, again, due to the patient's worsening status. So as we know, fluconazole is a moderate CYP3A4 inhibitor, and as a result, I had to adjust the TES-IVA, and we went with an every other day dosing strategy, interchanging between those 2 tablets daily. On day 28, we got our first meropenem level, which was obviously high because of the aggressive dosing strategy. It was interesting, though, because we had all those factors on ECMO that we thought would bring the level down, resulting in more aggressive dosing strategy, but we actually had quite a high level at greater than 80, which was not quantified. A day later, our patient was actually able to come off the circuit. On day 32, they developed an acute AKI, so we decreased the meropenem vaborbactam to a dose of 160 milligrams per kilo per day, every 6 hours, infused as a continuous infusion. And then on day 33, some would say by luck, the FDA approved ETI therapy in their age group. And on that day, we had baseline lab values for LFTs, which were within normal limits, and we immediately converted on the day of approval to triple combination therapy. And we did dose modify to account for the continued fluconazole prophylaxis, utilizing every other day dosing. So now at the start of highly effective modulator therapy, we were on Trikafta, cefiderocol, minocycline, and meropenem vaborbactam as a continuous infusion and inhaled aztreonam. As our patient progressed from day 42 to 49, I just want to call out the meropenem levels at this time. On that dosing strategy, they were 36 and 41 respectively. With the dose of 41, it was recommended to increase the dose by our ID team, and the level a day later was 34. The PICU team on day 50 was attempting to wean off of ECMO and do capping trials, but the patient was not tolerating, and on day 52, we initiated inhaled meropenem at a dose of 500 milligrams Q12. On day 53, our meropenem levels, we noted, were not increasing despite subsequent dose escalation. And we did our own little study where we got a level from the patient, which was 39, a pre-oxygenator level, which was 30, and a post-oxygenator level, which was 26. And it really, again, went against our hypothesis that we weren't seeing higher levels in the patient in pre-oxygenator versus a substantially lower level post-oxygenator. And we had a couple theories that maybe It was due to the frequency of circuit changes and that could be inconsistent amongst the literature and the case series, that you're not going to have a standard amount of times that you're changing out the ECMO circuit or what your temperature management is going to look like from one circuit to the next or one case to the next. So there's a lot of variables when it comes to ECMO that can really make inferring the data and extrapolating to your patient and what the expected levels are going to be difficult. On day 60, we retrialed ECMO capping, which the patient actually did tolerate. And on day 64, we had our first no growth of Burkholderia culture result. Because of that, we decided we needed to start to de-escalate therapy because our patient was improving. So on day 66, we decreased the dose of meropenem vaborbactam. And on day 69, we discontinued cefiderocol. I was also able to persuade ID to, although I could not get them to stop the fluconazole prophylaxis entirely, they at least transitioned it to an agent that allowed for full dosing of highly effective modulator therapy, as I thought that there were significant changes happening after initiation, and that full dosing may be of additional benefit to our patient. Through days 71 to 122, the biggest thing I want to point out here is that we had overall improvement for our patient. So they were ultimately decannulated on day 71. Cultures were repeated throughout the rest of the stay, and there was no growth. We ultimately discontinued antibiotics, minocycline, and meropenem vaborbactam by day 122. I wanted to call out the summary of my findings from day 33, which is the day we initiated highly effective modulator therapy, and that although I can't put all the credit onto highly effective modulator therapy, I do want to point out that during the time that they were on it, 24 hours post to 1 month post, we didn't have any adverse effects that I could correlate back to the initiation of the therapy. Bronchoscopy by 1 week post-initiation showed significant decreased burden of secretions, the left lungs were clear, and they had healing of respiratory mucosa that was previously friable and damaged. Their chest x-ray by 1 month post showed overall significant improvement in aeration, where previously there was patchy airspace opacities and severe ARDS. And then by 1 month post, again, we did not have any growth of Burkholderia on any of the cultures that we were obtaining. On day 138, our patient was ultimately discharged home on a regimen of inhaled meropenem, 500 milligrams Q12, eventually transitioned that to a rotating every other month and then ultimately off. And that was in coordination with their outpatient PFT and clinical status. Lexicaftor, tezacaftor, ivacaftor was maintained on full dosing for our patient, and all their other prior to admission medications were restarted on discharge. And to date, they have not regrown Burkholderia gladioli. So the major takeaways for us were that ECMO had a multitude of implications on the dosing of antimicrobials that warranted the need for continued PK modeling, and consensus guidelines are recommended and something we should consider. CFTR modulator therapy administered in the setting of ECMO and CRRT appeared to be safe and efficacious for our patient and arguably beneficial for ultimate organism clearance and lung improvement. And the utility of serum meropenem levels, although informative, may not be applicable in a more complex clinical setting where you have multiple variables going on to consider. And although you may not be achieving your goal levels or what you're extrapolating that goal level to be, you can still see clinical improvement. And then lastly, I just want to give a shout out that this really was a multidisciplinary team approach, and that's prudent for us to think about in the successful management of our patients with CF who are admitted to higher levels of care, requiring frequent therapeutic drug level monitoring and overall support in their transitions of care as we monitor those PK and PD changes over their stay. And with that, I'll take any questions that you may have. Thank you.
There are a couple in the chat. First, were you able to get any levels for any of the antibiotics that he received?
Aside from the meropenem? No, we were just following the meropenem levels at that time. That was our focus.
And then did you draw any beta-lactam levels while on ECMO?
Yeah, so the meropenem levels were all on during the ECMO course. Other than the meropenem levels, we didn't draw any other ones. They were, the only time study we did was that one set of levels where we did the patient pre and post. Otherwise, we didn't repeat that strategy again to see if there are any changes. The rest were just serum levels from the patient throughout the course.
Okay. With short stability of IV meropenem, what administration strategies did you use to achieve 6-hour infusions?
Related to, is that related to compounding or? I don't know who asked that. But I'm not sure.
It's
Okay.
For 8 hours.
Yeah.
My hospital room was good for 4 hours, so what did you do at the bedside to achieve 6 hours?
Our stability is for 8 hours. So we were able to achieve each. So essentially what we were doing is we were dispensing a dose to be given over 8 hours, and that next infusion bag came for the next 8 hour, 6 hour dosing interval. Yeah.
Any other questions?
Oh, any insurance issues with inhaled meropenem at home?
Surprisingly, no, and I have to give a shout out to our specialty pharmacy for that. But no, they were a huge help, and we didn't have any issues. We had some issues with renewing, but that initial discharge home, there were no issues. But we were able to justify, we provided an extensive summary of the hospital course, and were able to get it approved for the remainder of the time we had him on it.
Are there any PK changes you would anticipate with ETI in setting of ECMO?
Yeah, so that's something I really wondered about because I could not find any good guidance in the literature with doing it. But I think there were enough, again, compounding variables that I figured at a minimum, full dosing, see what happens. And I didn't expect that the protein binding concerns were going to be or warrant or justify me doing anything like doubling or going up on the dose or providing any more. I thought that the risk benefits of going up on it, given his critical state, and we had, knock on wood, very good management of his LFTs and other adverse effects, so I didn't want to push the envelope, and I was really leaning more on safety versus efficacy, but I think the trajectory of the case post-initiation on standard dosing really showed or proved the efficacy there, and that there wasn't really a need to keep pushing the envelope past that.
All right, well,
Thank
thank you
you.
very much. Okay, thank you very much for that presentation, Dr. Rosano. For our last presentation to close us out, we have Dr. Jeffrey Zobel. Dr. Jeffrey Zobel is an advanced clinical pharmacist at Intermountain Primary Children's Hospital and the Intermountain Cystic Fibrosis Pediatric Center in Salt Lake City, Utah. Dr. Zobel has been involved with the Primary Children's Cystic Fibrosis Center for the past 16 years by providing pharmacy services to cystic fibrosis patients and dedicated to the clinic for the past 7 years. Dr. Zobel also serves as the co-chair for the Cystic Fibrosis Foundation Pharmacist Mentorship Committee and the CF Foundation Access Steering Committee. Dr. Zobel completed a PGY1 pharmacy residency at Intermountain Primary Children's Hospital. He graduated with his doctorate degree from the University of Arizona College of Pharmacy. Dr. Zobel will be presenting today on a topic of a successful case of demonstrating how to navigate on an alternate funding program. Dr. Zobel.
Thanks, Jenna and Kathleen. So just before I start, I'd like to give a shout out. We have some people from the CF Foundation here. So I've got Ozzy Cater and Olivia Dieni and Kelsey from the CF Compass. So they're here in the audience, as well as we've got two individuals from CF Specialty Pharmacy who are practice liaisons. So if you've never had a practice liaison or concierge from CVS Specialty Pharmacy, we've got two of them here. We've got Nina and Tynisa here on the second table. So if you need help with CVS Specialty, they're great. So anyone who's worked with them, they're great. So please talk to them, and they'll be able to help you with getting access to medications and addressing some of the issues we have with getting medications. So what my title is, we have the World Series going on. We got a Houston title here in it. We have Team Pharmacy 1, Alternative Funding Program 0. So this is the successful case of navigating how to negotiate with a alternative funding program, which we're able to successfully get get access for patients' medications through one of these programs. Okay, I have nothing to disclose. So the objectives, we're going to actually talk about what is an alternative funding program. Probably thinking, what is this? Matrix Model's another name. They've got some interesting names. I'm not going to shout out any specifics because I don't want any of them to come back at me, but they have weird names, and you'll figure out who they are once I start talking about them. We'll also summarize the ramifications of these programs as it affects us as pharmacists and patients, and then finally what we can do to counteract them and assist our patients and families in getting access to these meds. And special thanks to the CF Foundation as well as Basifian for her help with this presentation. So here's an actual fax that we received in 2021 that was very concerning, but I had no idea what this was. I'd never seen this before. I was like, what are we talking about? So I had the names of the patient. I blurred everything out, also the name of the program. But it said urgent, urgent, urgent. And we got this once, and I'm like, I threw it in the trash can, okay? Because I'm like, what is this? So then they got it again, and it said, this patient has this added benefit to their health plan that can help the member receive their medications at no cost. And I said, there's no such thing as a free lunch. This has got to be a gimmick. To proceed, you had to do these medications, but they had to get it by 3/15. You can see the date was 3/11. I'm like, great, they gave us 4 days to figure this out. And then, so they would not lose coverage of their medication. Please do this. I'm like, what is this thing that's going on here? So we got it, and they needed, it was for 2 patients, they were siblings, and they needed help to receive. I put brand names in there because that's what they were, but it's basically their enzyme, their mucolytic, and their modulator at no cost. And I'm thinking, okay, no cost, that doesn't exist in life unless you have a money tree. And I said, this notification came with copies of the patient access, the patient assistance forms through AbbVie, as well as Genentech, and then it also had the Vertex GPS forms. And I'm like, okay, that's weird. Why are we doing that? Because that is not a patient assistance program. So I don't know, what are we gonna do with this? So I called the program to find out what's going on. And this was our first experience. They told me because the cost of medications were too high, the company, HR, decided to carve out these medications, and so they were no longer covering them with no chance of prior authorization. And we needed to fill out those forms so they could get their medication at no cost. And if we didn't do it, it was our fault. I'm like, what are you talking about? So I told them that PAPs are not designed this way. That they're for people who don't have insurance, and we'd used PAPs before, and they should only be used if they lost insurance or employment issues. Well, this phone consultation kept going. They argued with me, and they said no. I had to fill them out, so I was the reason they weren't getting their meds. And I'm, okay, this got a little escalated. So people who know who Jeff's a bulldog. He does not give up. So I talked to the patient's mom, and she was told by her, a patient advocate from this company had called her and said if we didn't fill out the forms, it was our fault that she wasn't getting her meds, and she would then run out, so that's why we had to do it. They would get 2 courtesy fills, but these forms would get them free medications because their husband's work said they wouldn't cover them. So I called this patient advocate on the phone because I wasn't giving up, and I asked to talk to a supervisor who said they were doing this because the medications were too expensive. It was their way of getting back at the the pharmaceutical manufacturers. And I said, why are you doing that? That doesn't make a lot of sense. So then I called the manufacturer PAP programs, and I talked to their coordinators, and we worked out a way to actually get a denial of those PAP applications because PAPs, if they have insurance, the PAPs get denied. So that's why we kind of worked around it. I worked with the those individuals. I have names if you need them to get to these individuals. They're both kids, and we're going on. So then we filled out the forms. So we played their game. We filled out the forms, we submitted them, and then I called the PAP program and said, okay, deny them now. I've done my work, we did it, and they sent me denial letters, and we got them denied. Then I got the denial letters, and then I faxed them to this company, and I said, okay, the PAP application's been denied. What are we gonna do now? They need their meds. They're running out. And they finally decided to cover them and gave me override codes. However, it took several hours on the phone with my technician and myself to get our specialty pharmacy to be able to fill them. In total, it took over 15 hours of time and over 200 pages of paper. I can still have it in my desk if you want to see it. It's about this thick. How to get the meds to these just 2 patients. You're probably thinking, how does Jeff have that time? Well, the people around us can tell because they're like, Jeff, I hope that person on the phone realizes how mad you are. I'm like, yeah, they now know. So we're gonna go through some definitions, why these things exist. So first of all, a self-funded plan. Who knows what a self-funded plan is? Raise your hand if you know what one is. Okay, all right, that's why we have this definition, because obviously a lot of people don't know what a self-funded plan is in this room, or a self-insured plan. This is where the employer collects all of the insurance premiums, and assumes the financial risk for paying all the health care benefits for employees and dependents. These plans are not covered, they're not mandated under state insurance and laws. So if you have a copay accumulator ban in your state, that's great. It only affects about 30% of your patients. 70% of our patients in the United States have self-funded insurance through small companies, school districts, car dealerships. They're all self-funded. So if you see self-funded in there, they can do whatever they want because they have a law called ERISA, which is a federal law that was passed in 1974, which exempts them from all state laws. So if you are trying to get a copay accumulator ban in your state, or you have one, that's great, but it only helps a certain percent of your patients. Most of your employee health plan or your state employee health plans are self-funded, and they are exempt from this, any of these things. So self-funded kind of fall under different rules, and so a lot of these laws won't touch them because of this. Okay, a third-party administrator, or TPA, these are these entities that we're talking about. They're actually not insurance. They're a broker on behalf of some company that negotiates with a company, or maybe tied with an insurance company, that contracts an employer, processes and adjudicates the claims for the self-funded plan. So the self-funded plan can do whatever they want. They can exempt, carve out things, and then these guys come in and they say, hey, we'll give you a great deal. If you carve out these meds, we'll make sure they get them for free. And that's how they do it. And so it's a very, very kind of a scheme that goes around. You gotta kind of look at what's going on. And the reason they can do this is because it's called stop loss insurance or reinsurance, which is purchased by the self-funded employers to protect against any catastrophic or unpredictable claims over a specific dollar amount. We didn't really see this until modulators started coming out, and modulators are so expensive, that's where they do this, and they are exempt. These stop-loss plans are just insurance. It's not health insurance. So they're exempt from any of the provisions of the ACA. So they do not have to cover any essential health benefits, which these medications can be considered as such a health benefit. That's how they get around this, is because they're self-funded and they can get around the ACA as well as the state insurance plans, so that's why they fall into ERISA. So that's how they can get by this. It's a loophole that they can get through. And then we have our pharmaceutical manufacturer, PAPs, or patient assistance programs, which provide medications at no cost to individuals who meet specific qualifications, usually income, or they don't have actual health insurance. They've lost their job and they have to fill out the forms, and usually the doctors have to sign them as a prescription or send the prescription to a specific specialty pharmacy to dispense. So what are they doing? So they work with the self-funded employers-based plans to reduce costs by maximizing the copay assistance patient assistance programs or copay assistance programs for high specialty medications. They're targeting all the modulators as well as enzymes and Dornase alpha. Those are the ones you see it for. So usually you'll see your family they get a letter in the mail that says, you have high cost meds, you must sign up for this program or else. That's usually what they're doing. And the strategy is to reduce the specialty medication cost for the self-funded plans and assure that the patients will never go without medications. So this is their process, what they do. So the plan actually excludes, so they'll go to the employer, the plan will exclude the specialty medications from their formulary, and then these alternative funding programs come in and work with the member. They say they have a patient advocate who will work with them to help them get their meds. But actually what they do is they print out the forms from a website and send it to the center. You guys end up doing all the work, not them, but they get paid for it. And their payment is why the amount of free drug that they get, then they use that as a kickback to help fund these programs because they're not having to pay for the med. If the alternative funder program, they get the PAP information, and then there's members, if they enroll under the pretense of being uninsured, because they say it's not covered, so it's uninsured because the payer won't cover the meds. However, and then the PAP gets denied, the member can appeal for coverage from the employer, and then they may issue an override, but that's not guaranteed. We have some patients that have never gotten their med because of these, even though they have an override process in place. So how does this affect patients? If they're denied by the manufacturer PAP, the plan may cover it, but then they apply a copay accumulator on top of it. So even though it gets denied, they get covered, none of the medication information, of all the copay assistance money will not go towards their out-of-pocket maximum or deductible because it's classified as a non-essential health benefit and they circumvent the ACA. It can have a significant financial burden on patients and caregivers trying to get around this, because if they have a cost accumulator, now they may not get their med, now they get their med, now they can't, it doesn't get covered, it doesn't get paid for towards their deductible. And they may not be able to access during that PAP enrollment process in evaluation, because that can take sometimes a week or two, and some families have run out of medication. And they may issue month-to-month overrides and courtesy fills. So sometimes say, well, we'll give you another courtesy fill so you have a chance to get it. I don't want a courtesy fill, I want the med covered. That's what we want. So we don't want to do these courtesy fills because it's not really helping anybody. What else can happen to the patients? There's no guarantee the employer will cover the medication after the PAP denial because there's self-funded plan. We've been successful in getting it for this patient. We did get it, and we've done this about 5 or 6 other times. And they're getting smarter in what they're doing, because now we had one, the last time we had to do this, they tried to call the PAP and say, hey, no, it's actually not covered. No, you have to do it. And the PAP wouldn't talk to them. They'd call me and say, it's denied. And I got called 3 times, and I had our doctor call, and they yelled at our physician and said, why? They said, I was just a pharmacist. I could not be doing this. I was working in a pharmacy. And I'm like, no, I work in a clinic. No, you're just a pharmacist. And I was like, well, obviously you don't know who I am. So they figured it out really fast. And this individual, they ended up covering it, and that individual ended up not working there anymore because of that, because of the issues, because they weren't listening to what was happening. They were trying to exploit the system. But the patient may lose employment. That's the scariest thing about this. If you get coverage for it, the family then has no protections under the ACA, and they actually may lose their employment. So in talking with CF Legal, there's actually been several cases of patients losing their job without cause. They said it was for cause because, they did something. The one was the employee of the month, 1 month. 2 months later, they were let go because they were on one of these high-cost medications, and it was covered because that stop-loss insurance, no longer are they protected. It was costing the company too much money. We had one of these companies call me and say, okay, I know how much money this family is costing per month. I said, how do you know that? Well, it's a self-funded plan. They have all their data on all their employees because they're in charge of all of it. So they are keeping track. And so from CF Legal's aspect, if they're on one of these plans, get them off as quickly as possible. Get them in the marketplace, because at least there they have ACA protections. If a member eligibility changes anytime mid-year, so they may, go from one job to the next, or they have some sort of health condition that they have to do open enrollment again, that resets that TPA can come back and reset and take that approval away and deny it again. So you have to start the process all over again in appeal if they have any change in any mid-year with a third party. The ramifications is sometimes there's lifetime caps on, if what we can see is that sometimes the PAPs may institute lifetime caps. We've seen it with with the Pomozyme copay card, you get like a one-time voucher. We used to have the free cards, you get it one time for the entire life of the patient. That's something we're worried about. We are seeing the second one, retaliation for manufacturer copay assistance programs. Guys, this is happening right before our eyes, right now, in our environment. If you are not aware of the Vertex copay changes, wake up and realize that it's going to affect our patients. January 1st, Patients may run out of med if they're not able to get their meds. So this is real. They are retaliating against these type of programs and copay assistance programs and putting our families and patients in the middle. If you haven't been helping with this, we are the people that have to do this. I've worked all week with families every day calling about insurance. Open enrollment happened this week. So please, please, please be aware of this. It is happening and is real and is wrong what was happening to our patients. And they are the ones that are going to suffer, and we are suffering because we have to do extra work because of this. Because of programs like these, but the manufacturers are retaliating back, and we're seeing that right now. Foundation copay assistance programs. HealthWell is going to get hit really hard by this. They're not getting any extra funding. Please go to Fred Larby at HealthWell and give him a hug, because he's going to be our lifeboat for a while. Those other programs are closed. They're the only one that's open right now. So please, please, please help and get the word out to your center directors and to everybody. This is something we have to do as a pharmacy community to help these patients with CF Compass and CF Legal to get this thing resolved for our patients, because they're the ones that are going to have to see it. We don't want them to suffer. We don't want them to go without. It's our job to help them. If the PAPs are approved, they must be filled with a different specialty pharmacy. How many pharmacies do people have to go through? And now you're adding another one on and another one on. So if they have 3 PAPs, three free drugs, that's 3 extra pharmacies they have to deal with, that we have to deal with, and they're not easy to deal with pharmacies because none of them have concierge like CVS, like Accredo. These are rinky-dink pharmacies out in the middle of nowhere, Sendera, they're Lumicera, they're ones that we can't contact, so that's where they're at. So you have to be aware of these. What can we do? What's going to happen to us? The administrative burden on our care teams must apply to all these programs. Paperwork, paperwork, paperwork. Justin, my tech, can attest to this, how much paperwork it goes through and how many calls to be online with these individuals and the time it takes. We don't have a lot of time. We're trying to take care of patients, and we're trying to do this for 1 or 2 patients at a time. It doesn't work. And then all the multiple manufacturer-approved pharmacies we have to work with, phone calls, and frustration. But educate yourselves about insurance. If you don't know about insurance and what the marketplace is, educate yourself. What is a copay accumulator? What are fully funded versus self-funded plans, and the pros and cons of the marketplace? Become familiar with these alternative funding programs, their names, what they are, what are they doing, because this is what they're doing, is they're trying to weasel their way into to get the drugs for, not have to cover the meds. And then be familiar with the PAP programs, that some don't just provide free meds for insured patients. They have stipulations, and be proactive. Educate your patients and caregivers, play their game. Fill out the PAPs if you've got to do it, fill them out, and then get the denials. That's about the only way you can do it, and be persistent. Don't give up after you get that first denial. Keep going, because eventually they will give in, because they'll concede because they want to get the med to the patient. Hope is on the horizon, so there is a lawsuit in May that came out May 4th of 2022. You can access this online. One of the manufacturers, Johnson & Johnson, against Save on SP, is a copay maximizer program, alleging that they're circumventing the ACA from this essential health benefit through deceptive trade practices. Then they overpaid for greater than $100 million in copay assistance. If the court sides with J&J, we may see a change in these type of programs, and they may end up going away, but they'll probably just morph into something else. There is the Help Insure Lower Patient Copays Act as a House Bill 5801 that was introduced in November 21 to ban copay accumulators, but this really probably has no legs because it hasn't left even the committee, hasn't even seen by a committee in Congress, and we know midterm elections are happening next week. This is not going to go. Who's going to worry about this? They're worried about re-election and other things. So this is I don't think this is going anywhere. And CF Compass has the same thoughts. This does not really have any legs as a federal, and it won't do anything to self-funded plans anyway. So only will affect about 30% of our patients. Self-funded, ERISA supersedes any other act that they would pass. There is a lawsuit by 3 patient advocacy groups against the Department of Health and Human Services and Center for Medicaid and Medicaid Services regarding that 2021 copay accumulator allowment. but we'll see what happens. It was filed in Washington, D.C. So conclusion, these programs are very complex and know what they're doing. The patient caregiver teams are going to be adversely affected. We're seeing this right now. We're going to be affected by this, but knowledge is power. The more we know, the better we can do to help our patients through these issues. So I do have this slide on here. So if you didn't see the webinar 2 weeks ago that we did, the CF Foundation, we did regarding the copay accumulator and the issue with the Vertex copay assistance changes, you can do the QR code to go pull off resources in the webinar that was recorded. So here's all the information. The CF Compass people are here to answer any questions regarding this, what they can do to help. So that's a good resource for that. And then the plug for the survey, Bob had me put this in here. So there's a plug for the survey. Shameless plug by Bob. So if you're doing the pharmacist survey of the value, because I was part of that original valuation, because I was talking with Joe here earlier, in this room, if we'd had this room like when I started 16 years ago, we probably could have been in this first group of tables, right? There's only about a few people. Who was here back in 2006? Or who was the CFP in 2006 in Denver? Okay, we're about 7 people. Look at this room now, guys. This is amazing to see these many pharmacists and technicians. Kudos to you guys. We're doing a great job. We can keep doing it, but we've got a lot of work ahead of us in the next few months. Thank you. I don't know if shameless, steal shameless, all right, no, share generously, steal shamelessly, right, Bob? There we go.
Okay, so there's a question. Do you have any concerns about the number of patients being transferred to marketplace plans to avoid these third-party situations? Is there a possible long-term impact on the marketplace system?
Yeah, there is. Anytime you load up the marketplace with changing the risk from one to the other, yeah, premiums are going to go up. Well, I mean, the marketplace is there. It's not going to change the marketplace itself, right? But it's going to change the risk pool, because that's, you don't want too much risk in that pool, because originally that's what happened. The concern was that too many people, unhealthy people in the market, then it's going to cause increase in premium. So yeah, this is going to, it's a whack-a-mole. We go from one, we're going to go to another. We're going to create another problem. These copay assistance changes magically are not going to go away. It's going to cause alternative funder programs to go after them. They'll change their game. They'll change their rules. So it's a never-ending cycle. But yeah, it's going to change the marketplace. Yeah.
Okay. Our GPS rep has been recommending patients call their insurance now to check if their modulator is covered. But from your presentation, it sounds like modulators could be carved out at any time. Do you see value in this recommendation?
So this is different. So these alternative payer models are different than your regular insurance. So if you have regular commercial insurance, they're not going to go after one of these. It's like a self-funded plan is going to do this. You'll find out differently. But if you try to call insurance, a GPS rep telling you to call insurance, they don't tell you. You can't find it. Don't try. The best is to have them have Vertex poll their copay assistance values for the last year. Look at what's happened. So your GPS rep can actually send you their last year of fills of their copay assistance. You can see if they haven't met their deductible by now, they're a copay accumulator plan, and you're seeing $5,000, $6,000 going through every month. Or look at HealthWell. If they're still having copays going through HealthWell in your portal, if you don't have the HealthWell provider portal, get it. That's a way I would look on the back end. If you have the Pulmozyme portal, you can see the Pulmozyme portal. If you don't have the Pulmozyme portal, get it. Because that's the only way you can see what's happening. Or you can talk to your concierge people like Tynisa. She can actually pull a report and look at or Nina, they can look at report what's going through, and they can tell you if it is a copay accumulator. That's the best way I found to do it. And what I've been doing with my Vertex GPS rep is I've got my Vertex portal open, and I got her on the phone. She's calling them, and then I call that family back and tell them, okay, this is really what you need to do. And giving them real-time insurance. It's taking a lot of work. I did a lot of hours last week. I'm doing a lot of hours this week. But our families, I've got 30% of my patients on copay accumulators. Utah is getting hit hard. If you don't have a lot of copay accumulator state, great. But Utah, we have a ton. I got a lot of patients to worry about. I got almost 100 patients affected by this. So it's a big deal for me.
Okay, there's a bunch. Give me just.
That's okay. Let's go.
Is the Save On Is the Save On program a TPA? I have not had to fill out PAPs for this program, but have had patients required to enroll after a PA is approved to obtain the medication at no cost.
No, Save On is not. It's sort of a TP, but it's through Express Scripts. So it's owned by Express Scripts, and it's their copay maximizer program. So copay maximizers or accumulators are different. A copay maximizer takes the copay card and divides it out by 12 and to maximize the copay card, but none of the money goes towards your deductible out-of-pocket max. The family has to sign on for it. Like Prudent RX is another one, and there's a new one through Navitus I just found out yesterday. They got one now. So you have to sign up for it, and when you sign up for it, the family gets a zero copay, but they have to give them the copay assistance information. Once they get the copay assistance information, then they get a zero copay. If they don't, then they have to pay an 80% penalty or the entire cost of the drug. And none of that money goes toward the deductible. So if you think of $25,000 for Trikafta, that family will be paying $25,000 out of their own pocket. That's what Save On does. And it's through a credo, and what happens, a credo goes to that fill, they fill it and say, oh, patient not signed on Save On, and then they get Save On the phone, and they get the copay assistance. And a lot of the pharmacies have the information, some of them don't, so then you have to provide it to the family to give to Save On. If they don't, then they won't get drug because it'll be too expensive.
Okay. The elephant in the room is medication costs. The medication cost is very hard for Medicare, Medicaid, self-insurance plans, et cetera, to absorb. This leads to patient access problems and higher premiums. Cost needs to be discussed more loudly by all of us.
I agree. The meds are too expensive, but that's on the manufacturer side. They need to worry about that. That's but what they're doing, if you look, most of the copay assistance programs with the med, they offer about 20 to 30% of the cost of the med is the copay assistance. In the case of what's happening with this Vertex change, they're offering $20,000, but the med costs $300,000. The math doesn't make sense. So that's why you have to look at it where the costs need to go down. If they drop the cost down to ICER levels, we may not see the copay accumulators, but that's why these programs exist, is the drugs are too expensive. But we can't control that.
Amen.
Point being that the talk, all that work that you just talked about, hours and hours and hours of work.
Right. And what we can't control that. That's the thing is we have no way of doing that. But they keep.
We're going to talk and spend a half an hour here about costs.
Right.
In addition to what you're doing.
Right. But again, I wish we could change the costs, but they have their own logistics that they're working out.
All right. How do you navigate this process for patients that are being considered for or initiated on modulators, especially if this information isn't readily available to patients and they may not yet be enrolled in GPS?
Well, didn't we hear yesterday Trikafta has been submitted for approval just 2 days ago? If you count out 8 weeks from yesterday or 2 days ago, where does that put us? February, February. Great. That's all I'm going to say is great. Thanks, Vertex. Thank you for helping us, and now we're going to be doing that on top of trying to help people. Now we have to enroll in GPS, and they've already done their open enrollment, and they have no way of changing that. So now they just set us up for another big boulder going down our hill. Sorry. I'm sorry, it's just a lot of work. And when it came out, 6 to 11 came out, that was one thing, right? I did 60 in a month. We went through, we hammered it through. We led the nation in getting them in a month. We got 60 patients on. We have multi-sibling families too. We have 65 multi-sibling families in our population, in our center. And so we got through that 6 to 11, and we just plowed through it. Now the 2 to 5, we're looking at another 100 patients that I'm trying to get on, and it's going to be a lot of fun.
If you go through the steps to get the PAP denial and push for insurance coverage, do you discuss with patients the risk of job loss or retaliation for those that work for employers with self-funded plans? And are you finding insurers to reluctantly cover with unaffordable copays?
We've actually had one family that got approved this year, and then they got a letter 3 months later that said, you're costing too much for our company, and you may need to look for another job. Yes, I have seen it, and it's not fun. So this family's now going to switch to Marketplace because of this. So it does happen. It is real.
How do you recommend approaching some of these self-funded insurance programs with the possibility of parents losing jobs after the company covers for a little bit?
Again, that's up to the company, but it's up to the family. You have to let them know the risks of what you're doing. But a lot of times they will work with their HR, but a lot of times HR does not know what this is. They were sold that they would get free drug, and then they realize, oh, it's really not free. And and then a lot of them have changed and gone to something else. So sometimes it does help to have that go through it, so then they can see what actually they're getting themselves into.
Thank you for this talk. This is one of the most difficult parts of what we do. I have never used Compass. Can you review how to utilize this service?
I think you just talk to them. We have Ozzy, Olivia, and Kelsey. They're great. You can call them or just kind of introduce yourself. They're right here. So I think just do that. I think that's the best way to get to know Compass. They're very helpful, and then they can give you resources. Or if you have a question, put on the listserv, right? We have a listserv. Hey, I've got an issue with these programs. What do we do? That's another option we can do.
Perfect. Just a couple more. Do we know why Vertex didn't use the credit card method to circumvent accumulators?
They actually did a credit card method. So if you were aware of, some of you had a pilot patients back earlier in the year. There were, 5 to 10 patients. We had about 15 in our center. The problem is that they didn't advertise it to anybody. So I actually had a meeting when they were going to release it. They said, okay, we're releasing this new thing. And I said, okay, can you tell me about it? No, we can't. I'm like, can you tell me the details? No, we can't. I'm like, okay, that's great. So then what was happening is we're starting to see on the health well side or the specialty pharmacies, the families would call and say, hey, I've got a $5,000 copay for my ETI. And I'm like, what happened? So then they would call it, oh yeah, they have the debit card. But they didn't give the debit card, and then you couldn't get the debit card because it was through a third-party vendor. You couldn't get the information. And then the specialty pharmacies didn't have it. They didn't know anything about it. And then it caused this rolling ball of fun that came down the road. And so what happened was then they ended up stopping, they're still in the pilot, but they were stopping it, and then they went to this. But again, they did not let Compass know what was happening before it happened. Be aware of that. They may tell you that, but our Compass people had no idea this was coming. We found out on September 19th, about the same time they did, but they just said this is a new change, but they didn't say, the details. So this came out of nowhere, and they did not vet the CF Foundation Compass people on this before they rolled it out.
Okay, it looks like we have time for one more.
Okay.
What can we as a pharmacy community do to band together and fight back on behalf of our patients while also navigating access issues for our individual patients?
Well, the problem is every state is different, right? You have different state laws, you have different legislators. So, knowledge is power, yes. But, I think the best is to go with CF Compass, and you can get Mary Dwight on your side, and Livia and Ozzy. We had an issue in Utah where our state employer plan was not paying for modulators at all. They wouldn't even cover Kalydeco, which had been out, and they said, well, because it's too expensive, and they put a copay on it, but then they wouldn't approve it. They only had it for one mutation, G551D, for ivacaftor, and this was 2020, 2019. And we were in a meeting with, Mary flew out, we met with our lieutenant governor who has 2 siblings with CF, and we sat in a room with the Vertex people and with the state employer health plan, and they were saying, well, we cover ivacaftor. I said, no, you don't. Well, yeah, we do. No, you don't. I said, I've had more denials of ivacaftor than any other drug. And they sat there and they couldn't come up with some policy that they couldn't figure out. And finally, we hammered it out, but we had to use the might of multiple people getting involved. But the listserv, I think, is good. Coordinate with different people. If your state, in your states, right? If you have pharmacists, multiple pharmacists in the state, band together if you need to get a law passed. Work together, not against each other. But in some states where you only have one, or you have adult center, adult counterpart, I work with Dave and we work on the advocacy. We were both there in the room with Mary Dwight. But I think that's who you access, is get the CF Compass advocacy group involved, as opposed to trying to battle it on your own.
We have just one more question.
Okay.
Where Where did it go? Oh, what do you recommend families look for when choosing a plan on the marketplace?
The problem is some marketplace plans have gone to cost accumulators as well. That's because of this HSS ruling in 2021. Marketplace plans can also do copay accumulators. So the marketplace is not exempt. That's why they're doing this lawsuit against them, because this was a previous presidential administration's decision that came out in 2017. So a lot of you, if you weren't in practice in 2017, these are brand new, right? Well, if you saw before this, they would fit one fill of Trikafta or Cambie, they'd meet their deductible. But starting in 2017, these started coming out, and it's hard to see. But the main thing you will look at is, does their manufacturer assistance go towards your out-of-pocket maximum deductible? It should be in print. It's supposed to, but all the ones I've seen, it's not. So you may just have to have them call. And a lot of times you don't say, did the meds go towards deductible? Say, does manufacturer assistance go towards deductible? And if they say no, then that's a copay accumulator plan. Or if you see Prudent RX or Save on SP at the bottom, that's also an indicator that it's a maximizer plan.
Well, thank you so much, Dr. Zabel, for this outstanding talk. Thank you all for your attendance this morning, and thank you for attending our session. Have a great conference.
Thank you.